Okay. Welcome everyone to the Warrior University class of this online platform in curriculum-based education. My name is Dominique Goodson, and I work with the Consortium. Our presenter today is Dr. Peter Lane, and he will be presenting on pediatric hydroxyurea in pediatric SCD patients. And Dr. Lane, I am handing over the presentation rights to you now.
Okay. So,
and you can share your screen and begin.
all right. Can you see that?
Yes, we can.
Okay. The wonders of modern technology. Okay. Well, good evening, everybody. I'm really delighted to have been asked to provide this webinar presentation, and as Dominique said, it's going to focus on the use of hydroxyurea in children with sickle cell disease. The objectives for this presentation are shown on this slide. The first is to understand how hydroxyurea works to make the red blood cells healthier in people with sickle cell disease. Second, to understand the clinical benefits of hydroxyurea. Third, to understand the possible side effects of hydroxyurea. And then lastly, we'll review the current recommendations for use of hydroxyurea in children with sickle cell disease. This slide shows the outline of the presentation. We'll start with a very quick overview of sickle cell disease, including the effects of the sickle hemoglobin on the red blood cells themselves, and on how the sickle red cells cause problems throughout the body. Then we'll turn to discuss the importance of fetal hemoglobin levels on the severity of sickle cell disease. And we'll talk about that because as you'll hear, hydroxyurea raises the level of fetal hemoglobin in the red cells of the people who use the medication. We'll talk about how hydroxyurea makes the red blood cells healthier, talk about the specific clinical benefits that can be expected from hydroxyurea, talk about the side effects, and then review the current recommendations for using hydroxyurea in children. And at this point, I also need to acknowledge that my friend Dr. Jim Ekman gave a presentation last Tuesday, a week ago, where he also discussed hydroxyurea and reviewed a lot of information about hydroxyurea with a focus on how hydroxyurea is currently being used in adults. So there'll be a little bit, I hope not too much, of possibly a little bit of repetition in this presentation, but for anyone who might have heard Dr. Ekman's talk, hopefully this will build on that. All right. Well, I know that all of you, I'm sure, know about sickle cell disease. You know, of course, that it's a genetic or an inherited disease caused by the presence of sickle hemoglobin in red blood cells, and that the sickle hemoglobin damages the red blood cells. And of course, the red cells are the cells that carry oxygen from the lungs to the rest of the body. We know that in the U.S., over 100,000 persons currently have sickle cell disease. And of course, there are different types of sickle cell disease. And the most common kind is SS disease. So this is sickle cell caused by the inheritance of a sickle gene from both mother and father. And the other kind of sickle cell anemia is the sickle beta 0 thalassemia. And about 65% of persons in the U.S. who have sickle cell disease have these two kinds that are collectively referred to as sickle cell anemia. Of course, there are other kinds of sickle cell disease, like sickle hemoglobin C disease and like a different kind of sickle beta thalassemia, the sickle beta plus thalassemia. And those forms of sickle cell disease altogether comprise about 35% of persons in the U.S. with sickle cell. And I'm making a point about that because, as you'll see, how hydroxyurea is used differs between individuals who have the sickle cell anemia types of sickle cell disease and those who have the other types. And of course, the main problem in sickle cell is that the red blood cells function abnormally because they're full of sickle hemoglobin, and that causes two main problems. The first is that the red cells don't survive as long as they should. In other words, each red cell doesn't last as long as a normal red cell would. That process of the premature breakdown of red blood cells is called hemolysis. And of course, that results in anemia, which is another way of saying a low blood count. The other problem with these abnormal red cells is that they cause blockages of blood flow. The fancy word for that is vaso-occlusion. And whenever the blood flow is blocked, that causes pain and tissue and damages tissues and organs, and this can occur throughout the body. Now, the hemolysis, the shortened survival of the red cells, and may I ask, is my pointer that I'm wiggling around here? Can folks see that?
Yes, your screen is still visible.
It is. Okay, good, because it might be helpful to use it at some point. Okay. So because of the shortened red cell survival, the hemolysis, individuals with sickle cell disease, and it's variable among individuals, have chronic anemia or low blood count. The breakdown of the red cells causes an elevation in the bilirubin in the blood, which causes the yellow jaundice that some folks have in their eyes. There's an increased risk of developing gallstones, even during childhood. The shortened red cell survival predisposes folks to something that we call an aplastic crisis, which is an acute worsening or exacerbation of the anemia during viral illnesses. Low blood count can also cause decreased energy, exercise intolerance. And in children, we know that those kids with sickle cell disease who have the most severe anemia also have some delay in growth and their pubertal development. And that's from hemolysis. Now, the issues that are caused by the vaso-occlusion or the blockage of blood flow, I think are nicely depicted by this cartoon, which demonstrates that basically that normal red cells are nice and round and they're slippery and they're easily deformable and they flow smoothly through the blood vessels. On the other hand, sickled red cells and the cells of individuals with sickle cell disease are abnormal in the ways we've already mentioned, and from time to time that causes an obstruction of the blood flow, and depending on where in the body that occurs, that determines what symptoms the person might be having, whether it's a severe pain episode in your shoulder or in the elbow or perhaps in the hip, or more concerning if, for example, there's a blockage of blood flow in the brain, then that might lead to a stroke. Now, so all of the problems of sickle cell disease ultimately are the consequence of the abnormal red blood cells. So we have the hemolysis, the shortened red cell survival, and then we have these issues of vaso-occlusion and blockage of blood flow. And Actually, sickle cell disease, I like to think of as being, on the one sense, pretty simple. It's all about the sick or abnormal red blood cells. That's the cause of all the problems. On the other hand, it is somewhat complicated in the sense that individuals vary with sickle cell in terms of how much hemolysis and how much vasoocclusion they have, and therefore, and how the hemolysis and the vasoocclusion sort of combine to cause a complex progressive damage to blood vessels over time. And this damage to the blood vessels that's caused by the sickle cells leads to the acute kind of complications of sickle cell that you are all familiar with, like acute episodes of severe, sometimes excruciating pain, splenic sequestration, and increased risk of infection, acute chest syndrome, which is like a very severe kind of a pneumonia, stroke, and priapism. And also, this process and this chronic damage to the blood vessels that's caused by these abnormal red cells ultimately over time leads to chronic organ damage. So the spleen doesn't work properly. Some folks end up with chronic pain, chronic lung disease, neurocognitive defects, in other words, difficulty with learning in school, pulmonary hypertension, which is high blood pressure in the lungs as opposed to high blood pressure in the rest of the body, and nephropathy is kidney damage. Of course, the other problem that everyone is aware of is that when these complications happen, often treatment is required, and then things get complicated by the complications of the treatment that is needed to help to address the complications that have occurred. And that can be the toxicity or side effects of whatever medication might be used. If transfusions are needed as a treatment, iron overload is a problem. Red blood cell alloimmunization is a complication of transfusions where an individual makes antibodies that complicate the transfusions. And of course, there's the word iatrogenic means basically bad things that happen to you when you're sick because you're in the hospital or you're getting treated. So inadvertent consequences of treatment. Of course, we also have the psychosocial complications of a severe chronic illness, like absence from school and work. For children, decreased academic achievement, decreased readiness to transition to adult life, and of course, like all chronic illnesses, lots of stress, depression, and a negative impact on self-esteem, and all of that ends up decreasing the quality of life, causing lots of morbidity, and that's the medical term for pain and complications, a shortened survival and early death, and of course high cost. So it is a complicated disorder, but at the end of the day, all of that is the result of these abnormal red blood cells, which are shown here. This is what the blood of a person with sickle cell anemia looks like under the microscope, and these are the red blood cells, and you can see that some of them have this characteristic sickled shape. But even the ones that aren't sickled don't work properly. So let me stop there and see perhaps if anyone might have any questions at this point. Okay. Hearing none, can I move on?
Yes, there's no.
Okay, so now we're going to talk about the importance of fetal hemoglobin in sickle cell disease. And so far I've talked about the fact that sickle cell disease is a problem of the red cells, and it's caused by the fact that almost all of the hemoglobin in the red cells is sickle hemoglobin or a combination of sickle hemoglobin with some other abnormal hemoglobin like hemoglobin C. It also turns out, though, that individuals who have sickle cell disease do have some amounts of something called fetal hemoglobin in their red cells. Now, fetal hemoglobin is the hemoglobin that we all had when we were in the womb, before we were born. And after birth, the amount of fetal hemoglobin decreases. And for individuals without sickle cell disease, it ends up by about 2 years of age being less than 2% of all the hemoglobin. But in sickle cell disease, most individuals have, to some degree, elevated levels of fetal hemoglobin. And it turns out that fetal hemoglobin is the good guy, because fetal hemoglobin helps make the red cells healthier, in part because it interferes and blocks the sickling. So we know, for example, that individuals who have sickle cell anemia, who have relatively higher levels of this hemoglobin F or fetal hemoglobin in their red cells than do other individuals with sickle cell anemia, that they tend, as a group, to have less severe disease. And we've known that for a long time. This graph just depicts, shows the effect of relatively low, less than 8.6% fetal hemoglobin, compared with relatively higher, greater than 8.6% fetal hemoglobin. So individuals that had the higher level of the fetal hemoglobin compared to the lower level of fetal hemoglobin, that improves survival. Now, this is not treated with hydroxyurea. This is just individual variation. And so this shows over time. This shows up here, 1 is 100%, and this shows the percentage of individuals who are surviving at these different ages. And so you can see that the individuals, if we just take this 50% or 0.5, that without treatment with hydroxyurea, for example, about 50% of the individuals with sickle cell anemia who have the relatively lower amounts of fetal hemoglobin would survive to about 50% would still survive past 40 years of age, but you can see that for the individuals who have higher levels of fetal hemoglobin, the survival is significantly improved. And this led, this observation that had been known for many years led to a lot of research to try to figure out if there would be some kind of treatment or medication or a pharmaceutical agent that would increase the fetal hemoglobin in individuals with sickle cell disease, because it was expected that if we could find a medicine that would increase the fetal hemoglobin levels, it would help minimize the complications of the disease and improve well-being. So the bottom line, jumping ahead, and this is what Dr. Ekman reviewed in great detail last week, is that hydroxyurea does have beneficial effects in individuals with sickle cell anemia. And one of the main reasons it's helpful is that it does increase the fetal hemoglobin level in the red blood cells. And if you have higher levels of fetal hemoglobin, the red cells are healthier. And what does that mean? That means that the red cells are more flexible, they last longer, and so there's less hemolysis or breakdown of red cells and therefore less anemia. It also means that higher fetal hemoglobin levels, that the red cells are healthier because they're not as sticky to the blood vessel, to the lining of the blood vessels. There is less sickling of the red cells, and that means there's less of the vaso-occlusion, which causes the pain and damage to tissues and organs. In terms of the effects of hydroxyurea on the blood, when you look at blood counts, the effect for most individuals is that the hemoglobin level goes up. So that a person whose hemoglobin level might, without hydroxyurea, be 7 or 8, might now be 8 or 9 or 10. The other thing we see is that the size of each red blood cell, the red cells get bigger. That's the MCV on the blood counts, and bigger cells are healthier cells. And as a result of having healthier red cells that last longer, you don't need, the bone marrow doesn't need to make as many new red cells or reticulocytes as it did before being on hydroxyurea. And other issues are, other benefits actually, are that hydroxyurea tends to lower the number of the white blood cells that fight infection and the platelets in the blood that help to stop bleeding. And this is actually a good thing in sickle cell because most individuals with sickle cell disease have, as their baseline, higher than normal numbers of white cells and somewhat higher than normal numbers of platelets. And it turns out that those increased white cells and platelets actually are involved in and play a role in how the blood vessels are damaged in sickle cell disease. And then the last thing that we know hydroxyurea does is it increases the levels of something in the body called nitric oxide. And nitric oxide is important because it helps to dilate the blood vessels. And of course, if the blood vessels stay dilated, it's less likely that they would become blocked. So it's all about the red cells. And this is a photomicrograph of the red blood cells of an individual with sickle cell anemia on the left. This is what their red blood cells looked like under the microscope before they started taking hydroxyurea. And after being on taking hydroxyurea for 6 months, on the right, you can see just it's visually evident that the red blood cells are much healthier, that very few of them are abnormally shaped, and what goes along with healthier red cells are the things we just spoke about. So this really is the only medication that we have to date that is specific to sickle cell disease in the sense that it affects the way the bone marrow makes the red blood cells in a way that the red blood cells are healthier, and therefore it affects the cause or the source of all of the problems that individuals experience. What Dr. Ekman reviewed last week was that in adults with sickle cell anemia who take hydroxyurea, it's been very clearly shown now, and this is now with experience of over 30 years, that hydroxyurea does increase the fetal hemoglobin in the red cells, that in adults it does decrease the severity of the anemia, it decreases the number of episodes of pain, it decreases the number of episodes of acute chest syndrome, it decreases the need for hospitalization, it decreases the need for blood transfusions to treat the complications of sickle cell, it improves the quality of life, and it does prolong life expectancy in adults. So what about children? Well, I'd like to review now briefly with you 3 of the most important key research studies that have been completed in the last 8 or 9 years that show clearly what hydroxyurea does, how it can be beneficial in children, what it does do that is beneficial, and also in one case what it does not do. And the first is this so-called baby hug study, which was a study that was done over 10 years ago. It was completed and published in 2011, and the study was designed to determine if hydroxyurea is safe and beneficial in children as young as 9 months of age, or in other words, to see if hydroxyurea would do for children what it does for most adults. Then there's the switch trial, which was a study that also was completed in 2011, and that was a study that tried to determine if hydroxyurea could be used instead of chronic blood transfusions for folks who have already for children who had already had a stroke and were on blood transfusions to prevent a second or a third stroke. And then the last of these three studies was the Twitch trial, which was to see if hydroxyurea could be used instead of chronic blood transfusions to prevent a first stroke in kids that we knew were at high risk for stroke. So this is just a couple of slides to show that, in fact, the Baby Hug study showed that hydroxyurea does in children what it does in adults. And this first slide shows the levels of the fetal hemoglobin. So this is 25% at the start, and these were young children, so their fetal hemoglobin levels were still relatively higher than what they would have been or will be when they're older. And what you can see is that in the blue line, these are the children who were not taking the hydroxyurea, and the fetal hemoglobin level just continues to fall. But the patients on hydroxyurea, the fetal hemoglobin goes up, and it stays higher and consistently higher than it would have been not taking hydroxyurea. The same thing happens with the blood count. So here, this shows the average hemoglobin. At the start, the average was about a hemoglobin of 9, and you can see that it went right up to an average of 10. And compared to not being on hydroxyurea, it remains higher throughout the 2 years of this study. This slide shows the differences between how many times individuals had chest syndrome on the left, had episodes of severe pain on the right, and again, the hydroxyurea, the kids who were taking the hydroxyurea in this study, which is shown in red, they had less acute chest syndrome, less pain, and also less dactylitis. This is hand-foot syndrome, which is pain in young children, and then also needed fewer transfusions than those who did not take who were not taking the hydroxyurea. So the bottom line is, this study showed that essentially for children with SS, sickle cell disease, and S beta 0 thal, hydroxyurea, it showed that it was safe, and it basically had the same effects in children as young as 9 months of age as it's getting late, I guess, had been shown in adults. The next thing that I wanted to review was the question of, well, could hydroxyurea be used instead of transfusions to prevent recurrent stroke? So this is a subset of children who unfortunately have had a stroke caused by sickle cell disease during childhood. And we know that once a child has had a first stroke, that they're at very high risk to have a second stroke. And the treatment that we have used for decades now to try to help prevent that second stroke is to receive chronic blood transfusions. In other words, blood transfusions usually on about a monthly basis. So the question here being asked is, well, could kids who had had a first stroke and had been on transfusions for a few years, if they were doing well, would it be safe to switch them from treatment with the transfusions to treatment with hydroxyurea? And the hope was that the hydroxyurea would be as good or almost as good as the transfusions. And the hope further was that that would have another benefit besides not needing so many transfusions, but it also would be helpful with the lessening the amount of iron overload that the patients had from continuing to be on transfusions. Just like these other studies, they could only be done if patients and families volunteered to participate in the research. In this study, 134 children who had a previous stroke and were on chronic transfusions to prevent another stroke entered the trial because they and their parents volunteered to be part of this clinical research. And unfortunately, what this showed was, the bottom line was that hydroxyurea is not as effective in preventing strokes, and something called TIA, which is a transient ischemic attack, which is kind of like a mini stroke where the symptoms go away, but there was still injury to the brain. And so the bottom line here is that, unfortunately, they had to stop this study because 10% of the kids who had been switched to the hydroxyurea had strokes, and none of the kids, I think, who stayed on the chronic transfusion had strokes. And similarly, there were more TIAs. And oh, by the way, also disappointing, the iron overload didn't turn out to be any different. So the answer was that hydroxyurea is not an effective treatment, or not as effective as chronic transfusions, to prevent a second or third stroke in children who've already had a stroke. The third study asked the question, could hydroxyurea be used instead of transfusions to prevent a first stroke? So these would be children who would be identified as being at high risk for stroke because of abnormalities on the transcranial Doppler or the TCD ultrasound that's used to determine which children are at highest risk for stroke. Again, the way that these children have been treated in the past was always to be on chronic transfusions, because we knew that was an effective way to prevent the first stroke. And in this case, the question was, well, if you were such a child and you were doing well on the transfusions, at some point after a year and a half or 2 years, would it be okay to stop those chronic transfusions and use hydroxyurea instead? And in this particular study, there were 121 patients who volunteered to be in the study. Half of them continued on the chronic transfusions, and half of them were switched to the hydroxyurea treatment. And the bottom line was that there was essentially no difference. And these curves show the TCD velocities in the patients, comparing the standard group that continued the transfusion and the alternative group on Hydrea, and essentially there was no difference. And thus, it turns out that for some of these children, hydroxyurea is an effective and safe alternative to blood transfusions to prevent a first stroke. So to summarize, the benefits of hydroxyurea in children are very similar to those that have been shown for a longer period of time in adults. So there's decreased severity of anemia, decreased number of pain episodes, decreased number of acute chest syndromes episodes, decreased number of hospitalizations, decreased need for blood transfusions, improved quality of life, and hydroxyurea can help prevent strokes in some, but not all, children who are at the highest risk of stroke. One other very important question about hydroxyurea is, well, all of the things we've talked about so far are mostly about those acute complications like pain and chest syndrome and stroke. What about, does hydroxyurea help to prevent the development of chronic organ damage over time? And certainly we are very optimistic that healthier red cells are going to lessen the development of chronic organ damage that's caused by those unhealthy red cells. But the extent to which this is a benefit of hydroxyurea is not yet clear. Now, what about side effects? And this is very, very important because it's obviously important to always think when you're considering any treatment for any medical problem, what are the possible side effects? Hydroxyurea, the short-term side effects are that it lowers the white blood cells and it lowers the platelet count. And so that's a good thing unless the white cells and the platelet counts are go too low. Because if the white blood cells were too low, that might increase the risk of an infection. And if the platelet count was too low, it would increase the chance of bleeding. And those side effects are predictable, and they are dealt with by adjusting the dose to get the right dose, and we'll talk about that in a minute. Some children experience nausea, although it's a small number. In my experience, about 5 or 10% complain that they may have some nausea after taking the medicine. And for most of them, if they start taking it right at bedtime, that seems to take care of the problem, because I guess by the time they would notice the nausea, they're asleep. Some children, particularly girls who might have their hair in traction, may notice some thinning of their hair. And the other common thing that folks may notice is that there may be an increase in the pigmentation or the darkness of the skin particularly under the nail beds or at the base of the nail. But these, for the most part, are infrequent, not severe side effects, and for many of the kids, I would say most of the kids, they really don't have any perception of any side effects when they're taking the medicine. What about longer-term side effects? One important concern is the fact that there have been now some research studies that have shown that for adult men, when they take hydroxyurea compared to before they took hydroxyurea, hydroxyurea may reduce the number of their sperm and the motility or the function of the sperm. And of course, that's a concern because if you have a lower sperm count or your sperm don't work as well, it might decrease the likelihood or the chances that you could conceive a child. Having said that, it's also true that hydroxyurea is one of those medicines that carries with it an increased risk for birth defects if the medicine is being taken by the father or the mother when the baby is conceived or during the pregnancy. And that's obviously dealt with by not taking hydroxyurea during pregnancy. And importantly, there is no evidence at all that hydroxyurea increases the chance of cancer or leukemia. Other important issues, though, about hydroxyurea, like I guess every other medicine, it only works if you take it. And for hydroxyurea to work, it has to be taken every day. Individuals with sickle cell disease, the bone marrow, all of our bone marrows, whether we have sickle cell or not, are making new red blood cells every day, all the time. And hydroxyurea only works if it's there, if you take it every day, so that it can have the beneficial effect in the bone marrow so that the red blood cells that are being produced every day are healthier. Another important issue is that you have to really take hydroxyurea every day at the right dose for at least 6 months before an individual can determine if it's really going to be beneficial for them or not. Insurance approval can be a problem for some folks. Another issue in small children is that they need to take a liquid form of the medication, not the capsules. And sometimes we have a hard time finding pharmacies that can provide the liquid formulation. And I think the biggest inconvenience for most of the families whose children take hydroxyurea is that they do end up needing more frequent monitoring with blood counts and clinic visits every 1 to 2 months, so that there's a trade-off that the children come to the clinic to get their blood counts checked more frequently than they would have if they weren't taking hydroxyurea. And of course, the trade-off is that the hope is that regularly scheduled clinic visits replace unscheduled inconvenient episodes of acute illness and ED visits and hospitalizations. And the reason they have to be monitored every 1 to 2 months is that we have to monitor for the side effects of the medicine, especially to be sure the blood counts, the white cells and the platelets don't go too low. We have to monitor to be sure that the person is taking the medicine every day and that they're beginning to have the beneficial effects on the blood. And then the other thing is that everyone's different. And it turns out that 2 children who are the same age and perhaps of the same weight, that what turns out to be the optimal dose or the ideal dose for those 2 children it can be very different. In fact, one child's best dose might be twice as much of the hydroxyurea as another child of the same size. And so one has to go through a period of adjusting the dose in order to be sure you get to the best dose that has the best benefit and is safe. And of course, the other issue is that, and I think this is very important for anyone with sickle cell or anything else, is that there's always the concern that any medication may turn out to have side effects in the long run that even we might not yet know about. So let me stop there and see if there are any questions at this point about hydroxyurea in children.
Yes, there's a question.
Great.
Isn't the advantage of fetal hemoglobin the fact that it has a higher affinity to oxygen, which is why those with night HbF have fewer complications?
It does have a higher affinity for oxygen. That's a very good question. But in addition to that, it dilutes out the sickle hemoglobin, if you will, and it directly interferes with the sickling. So the sickle hemoglobin, when it gets deoxygenated, it comes out of solution. It comes out of solution and forms what we call polymers, or these long, stiff rods inside the red cell. That's what changes the shape of the red blood cell. And fetal hemoglobin, the more fetal hemoglobin you have in your red cells that's mixed in with the sickle hemoglobin, the fetal hemoglobin inhibits or stops that process. So the more fetal hemoglobin, the healthier the red cells. So it's more than just the fact that it does have a higher oxygen affinity. Any other questions at this point?
Yeah,
Shall I move on?
There's another question.
Okay, great.
Okay. There's a perverse belief that hydroxyurea can cause cancer. Do you know where this comes from? Is it true?
It's not true. And I think the origin of it is that hydroxyurea is a medication that's been around for a long time. Hematologists have used it to treat a variety of blood diseases, including some kinds of leukemia, for many years before it was appreciated that hydroxyurea had this effect on fetal hemoglobin and therefore might be helpful in sickle cell. And like other chemotherapeutic medications, other drugs that have been used to treat cancer, many of them, in and of themselves, while they may help to treat the cancer you have, taking them over a prolonged period of time may increase the chance of getting a different cancer or another cancer. And so that was a concern. It turns out, though, that hydroxyurea in the doses that are used in sickle cell disease, and this has been looked at very carefully now, and patients with sickle cell disease have been taking this medication for now over 30 years, in adults anyway. There is no increased risk of developing cancer when hydroxyurea is used properly in sickle cell. Hope that answered the question. Any other questions?
Yes, there's another question.
Okay, great.
How much knowledge do pediatricians have on hydroxyurea, and what, if any, collaborations take place between hematologists and pediatricians? I just assume it will be easier for parents to take their child to the pediatrician, which is often closer than the hematologist, thereby making bi-monthly visits less of a strain.
Yes, that's a really important point, and I think that highlights the issue that a lot of how healthcare is delivered and what's convenient for folks depends on where you live. Here in Atlanta, we have, folks with children with sickle cell disease in Atlanta have pretty easy access to pediatric hematologists at our program because we provide care at 3 different locations. But yes, one of the things that we are trying to do is to increase the comfort level of general physicians, pediatricians, and internists in terms of getting them to the point where they would be comfortable monitoring and using hydroxyurea, knowing that there's a pediatric hematologist or an adult hematologist that they can call if they have questions, and that's what we're going to talk about next. Should I move on? Other questions?
Yes, you can move on.
Okay, so this brings us to the current evidence-based management recommendations for sickle cell disease that were published now almost 5 years ago. And this exactly speaks to the issue that the questioner just raised, which is that it is important to expand the number of healthcare professionals who are able and willing to provide care for sickle cell disease. And so the target audience for these recommendations included PCPs, or primary healthcare providers, and that would include pediatricians and other healthcare professionals who might not be sickle cell experts. And this document, which is available online, and here's where you can go to read it, contained the recommendations for health maintenance, in other words, things to do to keep a person with sickle cell healthy, management of acute complications, how to manage chronic complications, and then there was an entire section on the use of hydroxyurea therapy and also on blood transfusions. And the recommendations for children, for the use of hydroxyurea in children, are that for all of the patients who have the sickle cell anemia, in other words, the SS kind of sickle cell and the S beta 0 thalassemia, that we should educate all of those patients and their families about hydroxyurea, and that beginning at as early as 9 months of age, those children, and remember, bear in mind, this is about 2/3 of all of the children who have sickle cell disease in the country, that we should offer treatment with hydroxyurea to all of those children. And that's actually regardless of how severe the disease has been so far. And that's because we know from the Baby Hug study that starting Hydrea at a young age absolutely decreases the frequency of pain and chest syndrome and lessens the anemia. Now, another very important point here is that why would the recommendations use the word offer hydroxyurea instead of treat with hydroxyurea. And the panel that reviewed all of this evidence, some of which I've shown you tonight, felt strongly that the word offer should be used because we need to recognize that what makes sense for one family and one individual may not make sense for another, and that patients may view the pros and cons of treatment differently depending on their circumstances, and that patient and family values and preferences may differ, particularly when it comes to the downside of treatment, like how feasible is it to do all this extra laboratory testing and office visits, and also some practical issues about the availability of getting the drug in the liquid form for small children and even things like cost. And so therefore the panel strongly encourages shared decision-making and discussion of Hydrea with all patients. And that, of course, means that hopefully we are getting past the point where getting health care is an issue where you go see the doctor and the doctor, finds out about your health and does an exam and then tells you what he or she thinks is best for you. That's not how it should work any longer. The other recommendation with regards to children was that for the kids with the sickle beta plus thalassemia and the SC, that it is recommended that we consider using hydroxyurea for those persons if they have sickle cell associated pain that is frequent and severe enough that it interferes with daily activities or quality of life, but that it's a little less straightforward using hydroxyurea. And so the recommendation is that for those children, there should be a consult with a sickle cell expert in order to help the families consider the pros and cons. And then lastly, and we haven't gone into this tonight for lack of time, but treating with hydroxyurea, adjusting doses, maximizing benefits and safety for each individual, because everybody's different, does require that the physician who's prescribing the drug follows a well-established prescribing and monitoring protocol. This is not something where you just pick a dose and stay on that dose and then there's a lot of monitoring that has to go on to make it safe and to be sure that it works properly. So lastly, I just thought you might be interested to see how this progress in knowledge about hydroxyurea over the last decade has impacted the extent to which the patients that receive health care at our institution, at Children's Healthcare of Atlanta, are using hydroxyurea. So this shows you the percentages during this time from 2010 up through the end of last year, the percentages of children who have sickle cell anemia and who don't require chronic transfusions, and those are the patients that would be eligible to take hydroxyurea. And you can see that in the older age groups we've reached a point, and it's pretty much flattened out, that roughly 80% of all of the children over the age of 5 who are eligible to use Hydrea have chosen to take it and are taking it. And that in the young kids, from 1 to 4 years of age, that the percentage has increased to about 49%. And then the last slide, which is very important, is that we all recognize that each person is different and that not everything works for everybody. And that there are many circumstances in life and in medical practice that may affect how well a treatment works for an individual. And so my colleague, Dr. Quarmine, did a study published a couple of years ago where she looked at over 100 children who had started the hydroxyurea, and she looked to see what was the frequency of hospitalizations, inpatient days, ER visits, pain pain episodes, acute chest syndrome, and the need for blood transfusion or blood exposure, and she compared how often those things occurred for each child for the 2 years before they started hydroxyurea compared to the 2 years after they had started hydroxyurea. And basically, up here, hospitalizations 0.53 means that the number of hospitalizations was reduced to 53% of what it had been, so roughly half. And so this does demonstrate that in the real world, hydroxyurea can do what it is intended to do. And that's the final slide. So, and we're close to the end of the hour. So I guess maybe would we still have time for more questions, I hope?
Yes, we do. We have a question. Is the new drug Cyclos better for kids than taking the regular hydroxyurea?
Okay, now which new medicine? I missed the.
Cyclos.
Was it Cyclos?
Yes.
Okay, so Cyclos, yeah, this is a very important question because hydroxyurea until recently only came in two forms, really. There were capsules, which older children and adults can swallow, and those come in different strengths, 200 and 300 and 400 and 500 milligrams of hydroxyurea in each capsule. Or there's a liquid preparation that can be made by a compounding pharmacy, which basically means they're taking the hydroxyurea from inside the capsules and they're creating a liquid from it. Cyclos is a very new product that has just been FDA approved for children as young as 2 years. And this is a form of the hydroxyurea. So it's hydroxyurea, it's the same thing, where a tablet can be put on a spoon, and when you fill the spoon with water, it helps to sort of disperse or dissolve it so that it can be more easily swallowed. And it comes in convenient breakable size tablets so that you can actually adjust the dose, to within either 50 or 100 milligrams, so you can increase or decrease it as needed. So this is a great new formulation, or a great new way to be able to take hydroxyurea, but I don't expect, and I know that there's no evidence that it's better or worse than hydroxyurea that would be taken in the capsules or the liquid.
Thank you. We have another question. How does hydroxyurea work with EMBRACE? Is EMBRACE necessary if hydroxyurea is working well?
Well, that's a very good question. So to be sure everyone knows, EMBRACE is a new medication that's been developed for sickle cell disease. It's actually a form of glutamine, which is an amino acid that we all get some of in our diet, and there are amino acid deficiencies and problems in individuals with sickle cell disease, and it was shown in the L-glutamine research studies that taking L-glutamine every day had beneficial effects on sickle cell disease, and the study was done both among individuals who were taking hydroxyurea, but also those who are not. In terms of children, I would say that we have very solid evidence about how the benefits of hydroxyurea in children, and I think the data about the benefits in children of the glutamine are less clear. The other thing I would say is that I would hope. I think that glutamine is being considered, particularly for patients who are taking hydroxyurea and are not and are still having lots of problems with their sickle cell disease, but it would be in addition to the hydroxyurea. And that, of course, would be something that each individual patient would have to discuss with their individual physician. Hopefully that answered that question.
Yes, it did. Are there any other questions? Well, I believe that's all the questions. Thank you, Dr. Peter Lane, for this amazing presentation on hydroxyurea in children with sickle cell. It was amazing, and thank you so much. Thank you, everyone, for participating in the class and all your questions. The video will be posted, the recordings will be posted online in a few weeks. And please don't forget that on Thursday, we have another Warrior University class, Acute Chest Syndrome with Dr. Ekman. So please join in at 6:30. Everyone have a good day and enjoy the rest of your evening. Thank you all.
Thank you.
Thank you again, Dr. Peter Lane. Enjoy the rest of your night.
Yeah. Oh, it was my pleasure. I enjoyed doing it very much. I hope it was helpful.
It was. You did an amazing job. We are so thankful that you were able to do this.